Leland Stanford Jr. died in 1884 of typhoid fever. He died because the age of antibiotics remained a half-century into the future. In 1941, Albert Alexander was almost cured by an antibiotic, but he fell victim to a more contemporary problem, a drug shortage. When the few grams of penicillin available ran out, he died. The subsequent development of novel antibiotics became a raging success story, but that success may be devolving into failure as the commercial interest of many pharmaceutical companies has shifted away from antibiotics and toward more lucrative classes of drugs. Alexander Fleming's exhortation at the time of his receipt of the 1945 Nobel Prize in Physiology and Medicine, in which he warned about the development of bacterial resistance to penicillin resulting from its misuse, seemed for a time to be an undue fear. That somewhat innocent time, however, has passed as the problem of rampant antibiotic resistance in the face of limited development of new antibiotics is finally being recognized as a critical public health issue. At a congressional briefing in September 2013, representatives of the Infectious Disease Society of America, the Centers for Disease Control and Prevention, and the Pew Charitable Trust spoke to Congress of the need for them to take a number of actions to combat the problem of antibiotic resistance. They highlighted the comprehensive Centers for Disease Control report that provided a minimal estimate of more than 2 million infections and 23,000 deaths due to multi-drug resistant organisms annually in the United States, numbers which the CDC, in fact, believe are likely to represent significant underestimates. Furthermore, these estimates do not include at least 250,000 cases and 14,000 deaths due to Clostridium difficile infection, a problem related to antibiotic misuse. In their report, CDC recommends several core actions aimed at stopping the spread of antibiotic resistance. Among these is the improvement in the way antibiotics are used. That is, the same goal as that of antimicrobial stewardship. An effective antimicrobial stewardship program must be based on the clinical science of antibiotic use and the application of principles that aim at achieving the optimum balance in patient care. That is, both for the individual patient and for every patient to follow. We hope this course has provided a foundation that you will build on as you develop your stewardship practice or program. Using antimicrobials wisely is not a choice. It is the responsibility of every clinician and every patient. We all must embrace our roles as the guardians of antibiotics to preserve this precious, non-renewable resource and medical care as we now know it.